Hello, everybody. Apologies for starting late. Dr. Santosh Anand. I'll be covering recall sessions for INI SS HPV portion. So we'll go on to the questions, probable questions. So an MRI picture was given, particularly an MRCP picture, and the question was, what does it show? Whether it's TB abdomen, porcelain gallbladder, adenomyomatosis of gallbladder, or Crohn's disease. So you can see an arrow mark pointed towards the probable gallbladder, but the gallbladder has multiple small uh, pearl-like things in its wall. So that gives you the clue. It's adenomyomatosis of gallbladder. It is otherwise called as pearl necklace gallbladder. So it is called as pearl necklace sign. It appears as T2 hyperintensities in the intramural portion of the gallbladder. This is because of accumulation of cholesterol or mucin-like substances within the wall of gallbladder, which is otherwise adenomyomatosis. It is otherwise called as Atoll sign also. The next question is modified Marshall score does not involve. Now, the modified Marshall score is used for judging or categorizing severe acute pancreatitis. It doesn't involve one of these systems, whether it's central nervous system, cardiovascular system, respiratory system, or renal system. And the answer is it doesn't involve central nervous system. So it involves respiratory, renal, and cardiovascular system. Score of 0 to 4 is given, in which best is 0 and the worst is 4. And a cumulative score is taken. Okay. So further, the cardiovascular system's fluid responsive, non-fluid responsive, depending upon the pH of the patient, the score goes from 1 to 4. So any score beyond 2 is considered as organ failure. That is number 1, 2 or more. Any score 2 or more is considered as organ failure. The difference between transient organ failure and persistent organ failure is the presence of these symptoms for 48 hours or more. I repeat, 2 or more is considered as organ failure. Presence of these symptoms for 48 hours or more is considered as persistent organ failure. Now, what is the difference between hepatic bile and gallbladder bile? So the question was, what is wrong with the hepatic bile? So the options given include acidic in nature. Hepatic bile contains more water and sodium. It contains more bicarbonate. So the answer is the hepatic bile is not more acidic in nature. It is less acidic in nature when compared to that of gallbladder bile. So this gives you the composition of various elements in the bile when compared to that of liver bile versus gallbladder bile. As we can see, the liver bile is less concentrated. So that is why bilirubin, bile salts, water, cholesterol, fatty acids, lecithin, everything will be low. Sodium chloride will be more because it is more dilute, whereas potassium and calcium will be less. Okay, just remember, among electrolytes, potassium and calcium will be less in liver bile, whereas rest of the things, electrolytes will be less in gallbladder bile. Coming to other things other than electrolytes, it will be less in liver bile because it is less concentrated. It will be more in gallbladder bile because it is more concentrated. Now the answer is it is acidified in the gallbladder. Bile salts are the major organic solutes in the bile. Hepatic bile is alkaline and gallbladder bile is acidic. A subtype of pancreatitis is called as hypertriglyceridemia induced pancreatitis. Now, one among the following is false. The diagnosis of hypertriglyceridemia induced pancreatitis includes triglyceride level in the serum more than 300 milligram per deciliter with classical clinical features of pancreatitis. That's option A. Second option is statins can be started if suspicious of diagnosis, and plasmapheresis can be used in severe cases. So option A is true, option C is true. Statins can be used for hypercholesterolemia, but not hypertriglyceridemia, because fibrates are the one which are the drug of choice for hypertriglyceridemia. Now, in case of hypertriglyceridemia induced acute pancreatitis, you need to manage like any other pancreatitis. But one additional thing is plasma exchange definitively will relieve them of the antecedent cause if it is hypertriglyceridemia induced acute pancreatitis, particularly if triglycerides remain elevated. Now, if it is causing recurrent mild acute pancreatitis, one can start on fibrates, omega-3 fatty acids, and can add statins. Whereas if it is very mild, low-fat diet, alcohol avoidance, because alcohol causes pancreatitis. Those who have hypertriglyceridemia without pancreatitis, if they consume alcohol, the level of pancreatitis which they develop can be multiplied. Okay, they can try other modes of weight loss and glycemic control too. Now, one of the following is false regarding bile duct adenomas. The second most common site is distal CBD. It presents as intermittent jaundice and presents as subcapsular location. The answer is intermittent jaundice because the overall incidence of bile duct adenomas is 1.3% of all liver benign tumors. It is mostly benign in nature and doesn't turn malignant. It is mostly diagnosed incidental and rarely causes any symptoms. It doesn't produce intermittent jaundice so frequently. Now, if the second most common site is distal CBD, what is the most common site? Most common site is intrahepatic biliary radicals, and they are subcapsular in location. They are usually less than 1 centimeter in size. Earlier, they were diagnosed most common in the postmortem liver. These days, they are being diagnosed because of increase in the imaging. Now, one among the following is false regarding EHPVO. EHPVO will show liver extinction. Portal vein is replaced by collaterals. Massive splenomegaly with mild ascites. So, massive splenomegaly is usually not seen in EHPVO. Mild ascites can be seen. It will not show liver extinction. So, this also can be an option, but I was not sure what was exactly given in the exam. So, that's why I included this. So, given an option between these two, I would go for liver extinction, but very rarely this option would have been given. So if it is considered as liver function test is normal as option A, portal vein is replaced by collaterals by option B, massive splenomegaly with mild ascites as option C, then I will go with option C because moderate splenomegaly is seen in EHPVO, massive splenomegaly is seen in NCPF. So in comparison with EHPVO, NCPF and cirrhosis, portal vein thrombosis, cavernoma, and collaterals is seen in EHPVO, whereas dilated portal vein is seen in both NCPF and cirrhosis. Splenomegaly, though it is common in all three, massive splenomegaly is seen in NCPF because the brunt of portal hypertension is buffered by spleen in NCPF, whereas the brunt of portal hypertension is buffered by varices in cirrhosis, and EHPVO stands in between these two. Now, if you ask which part of the portal venous system does the brunt goes in EHPVO, then the answer will be portal cavernoma, and that is why biliopathy, portal biliopathy is very common in EHPVO in comparison with NCPF and cirrhosis. So, portal hypertension, what buffers spleen in NCPF, bile duct system cavernoma in EHPVO, that is why portal biliopathy is common, and in cirrhosis, esophageal and gastric varices. The next question is a 67 years old lady of a known case of symptomatic polylithiasis now presents with small bowel obstruction. What's the most characteristic feature which is suggestive of diagnosis? And the diagnosis is Gallstone ileus. Which among the following is most suggestive of Gallstone ileus? Leukocytosis of greater than 15,000 can occur in anything. Pneumobilia, cholangitis, and fistula. Now the thing is, fistula can be present. They have not mentioned specifically fistula between what and what. And one cannot be able to demonstrate fistula categorically in a cross-sectional imaging. Cholangitis can be present in a patient of symptomatic polylithiasis in multiple conditions like choledochal, Mirizi syndrome also. But pneumobilia in a patient with symptomatic polylithiasis causing a small bowel obstruction is classical feature of one of the triads called Wriggler's triad. So the Wriggler's triad has pneumobilia, radiolucent gallstone, and small bowel obstruction. Small bowel obstruction will be seen as multiple air fluid levels. Radiolucent stone can be usually seen in one of the areas of the distended intestine. That's the Wriggler's triad. So the next question is, a patient in a general body checkup has an incidentally found lesion in a tail of pancreas. Somatostatin receptor study revealed it to be a non-functional tumor. What to be done next? So again, it's an incidentaloma of a distal pancreas. Somatostatin receptor study these days usually is a dotatak or a dotatak scan, showed a non-functional tumor. What should be done next? So the options include distal pancreatectomy, splenectomy, spleen preserving pancreatectomy, and observation. So if they don't mention size, then it's very difficult to comment on what should exactly be done. So hypervascular lesions in pancreas, how the flowchart goes. Do a Dotanak scan. If the patient has metastasis, do a biopsy and treat accordingly. If it is greater than 2 centimeters, you may or may not consider tissue sampling, but strongly recommend surgery directly. But if it is less than 2 centimeters, you can safely observe the patient. Repeat a cross-sectional imaging. If you have done an CT, do an MR. If you have done an MR, do a CT after 3 months. If there is no growth, then depending upon patient's age and patient's comorbidity, whether the patient can be followed every year or not, you can decide whether the patient requires surgery or not. If the patient is more than 55 years old and comorbidities are there, then subject them for yearly radiological control. If that is not possible, then prescribe them surgery. So I repeat it again. Any tumor greater than 2 centimeter, suggest surgery. Any tumor less than 2 centimeter, for 1 year, every 3 months done scan, it is not growing in size. The patient is less than 55 years, do surgery. More than 55 years, having comorbidities, subject them to again annual CT or MRI surveillance. If growth is there, then subject them for surgery. If no growth, then safely observe them. This is for non-functional pancreatic incidentalomas. The next question is, middle-aged male patient presents with variceal bleed, jaundice, and infected spleen. Now I was confused with whether it was an infected spleen or enlarged spleen. So infected spleen was one probably a misnomer here. Now what are the treatment options? Now if we remove the infected spleen there, then this can be considered as a portal hypertension causing a variceal bleed along with jaundice, which may or may not be due to a stone in the bile duct. A middle-aged male usually can present due to alcoholism. So given the limited clues given, I would consider this as an alcoholic cirrhosis with portal hypertension causing variceal bleed with a choledochal causing jaundice. If that is the situation, I will go for EVL with ERCP. Now, if the other option is the middle-aged male option was not given, a non-alcoholic is specifically mentioned, then again, variceal bleed should be dealt with EVL. So that gives you a clue. Okay, any variceal bleed should be controlled with an EVL. Only then you can subject them for any later shunts, if at all they are non-cirrhotic, either Linton or Warren shunt or whatever, only as a follow-up of EVL. So an alcoholic cirrhosis with portal hypertension presenting with variceal bleed and choledochal causing jaundice, then I will safely go for EVL with ERCP. So lint and shunt and war and shunt, they should be done in selective non-cirrhotic portal hypertension cases following control of an acute bleed with EVL once the general condition is improved. These are not usually done in patients with cirrhosis with portal hypertension, which is the likely cause in a middle-aged male, and the most likely cause is alcoholism. So alcoholic cause of jaundice and infected spleen was the discussion which I had done. Okay. False regarding gallbladder malignancy, incidence is 3% in highly epidemic or endemic regions. Post-line gallbladder increases the risk of gallbladder malignancy to 10%. At presentation, 35% has nodal metastasis. Carcinoma gallbladder with jaundice, 66% unresectable. And the answer is post-line gallbladder has 10% risk of CAGB. Now, this option A given to me was not sufficient. So I could elaborate this. See, first of all, post-line GB or a diffuse calcification of gallbladder is no more considered as a risk factor for gallbladder malignancy. Only stippled calcification of gallbladder is considered as risk factor for developing gallbladder malignancy. So without any doubts, hands up, this is the answer. Now at presentation, 1/3 to half have nodal metastasis. So this option is also correct. 2/3 of the patients who present with jaundice in a patient of carcinoma gallbladder, they are primarily unresectable. But remember, not all, not 100% of CAGB patients who present with jaundice are unresectable. So there is a famous paper from G.B. Pant calling jaundice in a patient with GBCA is not sine qua non with unresectability, which means 1/3 of the patient can still be subjected to surgery after appropriately managing jaundice. Now, coming to this option, the incidence of gallbladder malignancy somewhere ranges between 0.3 to 3% in those having gallbladder calculus for more than 1 decade. I will repeat, incidence of CAGB in patients who are harboring gallbladder stones for more than 1 decade, particularly in the areas, northeast areas, ranges from 0.3 to 3%. So next question is most common site of ectopic pancreas, whether it's duodenum, whether it's Meckel's stomach, or it is jejunum. Now, ectopic pancreas develops due to embryological abnormalities, and the most common site is stomach. It is usually found within 6 centimeters from the pylorus because as the dorsal and ventral mesopancreas or the pancreas rotate, the ventral mesopancreas comes into contact with the distalmost portion of the stomach. That is why it is very common. It is also seen in Meckel's diverticulum. Now, how does it see in an endoscopy? They are usually sessile and rubbery. They are submucosal in location, and they are histologically identical with normal pancreas. It is not very uncommon to mistake this with a cyst or any other tumor and then subject them for surgery. If surgery is done, one will find a normal pancreas. So ectopic pancreas, the most common location is distal stomach, 6 centimeters from the pylorus, though it can also be seen in duodenum and Meckel's diverticulum. Now, what is this structure in a patient for orientation? So this is the head end of the patient. This is the leg end of the patient. This is right side of the patient, and this is left side of the patient. Now, the structures marked include IVC, aorta. Pauperization has been done. That is why we are able to see pancreas and duodenum lifted up by the assistant standing on the other side. Now, what is this structure? Options given include first jejunal vein, left renal vein, right renal artery, or the aortocaval node. I will go back to the picture. So this vein is the first jejunal left renal vein. I'm sorry, it says left renal vein. So left renal vein usually comes anterior to the aorta and joins the IVC. The other structures seen here include, this is the right gonadal vein. This is the area of iotocaval lymph nodes. We do not see any big iotocaval lymph node in this patient. First jejunal vein is usually not seen here. It is seen going anterior to the D3. Okay. Right renal artery is usually not seen after cauterization. So left renal vein, it defines the boundary between 16A2 and 16B1 of the para-aortic nodes. So the nodes between the IVC and aorta below the left renal vein is considered as 16B1 group of lymph nodes, and that is sampled for carcinoma gallbladder. If this is found to be malignant or harboring tumor, then CAGB is considered as metastatic, and usually we do not proceed for radical cholecystectomy. Now, the other use of left renal vein is left renal vein. The caliber of left renal vein is usually very close to that of portal vein. So that can be used for portal vein reconstruction. One can safely ligate and remove a segment of left renal vein between the IVC and the left gonadal vein. So the venous blood from the left kidney can be drained through the left gonadal vein. So one can remove a segment of left renal vein between the IVC and the left gonadal vein and can be safely harvested for portal vein reconstruction. Panter trial, what was it? What does it contain? Is it a step-up approach for minimally from minimally invasive? Endoscopy versus surgical approach? BARD versus open necrosectomy? The question is, what does Panter trial has in its objective? So the answer is, it is for severe acute pancreatitis, and the main aim or the comparison is with step-up approach from minimally invasive and compared to that of top-down approach or open necrosectomies. It doesn't compare endoscopy or surgical approach. It doesn't compare BARD versus open necrosectomy. It is basically a step-up approach from minimally invasive. So it has completed a long-term follow-up. Please note the spelling. The previous slide spelling was wrong. So initially, they randomized 43 patients for step-up approach and 45 patients for primary top-down approach. Step-up approach was found statistically superior in 40% of the patients in terms of decreased development of exocrine insufficiencies at the end of the study. So the primary endpoint was either death or major complications or recovery. Okay. So no difference in recurrent or chronic pancreatitis development, no difference in endoscopic or surgical interventions, no difference in quality of life or costs. And in long term, they have definitely identified that step-up approach used to develop less number of incisional hernias when compared to that of open necrosectomies. So two things were advantageous in step-up approach. Number one, decreased exocrine insufficiency and trend towards less endocrine insufficiency in step-up approach. Number two, in long term, decreased development of incisional hernias in step-up approach. The most common cause of metastasis to pancreas, the options given include renal cell carcinoma, lung cancer, melanoma, or the breast cancer. The answer is renal cell carcinomas. Now, what is peculiar or unique with renal cell carcinomas metastasizing to the pancreas? So it can happen after 10 years also, which means a patient had an RCC in one of the kidneys. We have done radical nephrectomy. Patient has been in follow-up for more than 10 years. If he or she presents with a hyper dense lesion in arterial phase or arterially enhancing lesion in pancreas, in a patient with a history of radical nephrectomy undergoing RCC long back also, first consider it as a metachronous metastasis. Laterality doesn't matter. This means those who had RCC in right kidney can develop metastasis in the tail of pancreas also. Those who had RCC in left kidney can develop metastasis in head of pancreas also. And it is the most common resectable metastatic lesion of the pancreas. ALPPS, which is not done in stage 1. So association of liver partition and portal vein ligation for staged hepatectomy. So it was classically done in secondary liver malignancies. It was a serendipity in which they went to do a major hepatectomy, but after doing a parenchymal dissection, they found that a patient will not survive with such a small future liver remnant. Fortunately, they had not ligated the supply, the complete supply of the diseased liver also. So they waited for 5 days to 2 weeks, then found that the FLR grew in size and the tumor containing liver or the diseased liver shrunk in size, and they completed the completion hepatectomy of stage 2. And that's how ALPPS evolved. So in stage 1 of ALPPS, ligation of right bile duct is not done, ligation of right portal vein is not done, or RHA is ligated. Okay. So ALPPS, which is not done in stage 1, we do not ligate the right bile duct. So this picture depicts you the classical ALPPS. So in this, we transect the liver completely up to IVC. Middle hepatic vein is ligated. Right portal vein is ligated. Right hepatic artery is kept intact so that the right liver doesn't go in for necrosis. The future liver remnant bile duct is divided and bilioenteric anastomosis is done with Roux by jejunal limb. So we don't ligate the right bile duct. Many a times it may contain a tumor too. We do not ligate the right hepatic artery, but we ligate the right portal vein. So modifications for ALPPS came because of significant morbidity of ALPPS. Almost 50 to 70% of patients undergoing ALPPS had significant morbidities, including prolonged ICU stays, biliary sepsis, septicemias, and patients having ventilator dependence. The mortality of classical ALPPS ranged somewhere from 30 to as high as 60%. So then came certain modification, including partial ALPPS, in which only half of liver was transected, parenchymal resection. Middle hepatic vein was not ligated. This anastomosis was not done. So all these were done in second portion of stage hepatectomy. The second was RALPS. Instead of surgically transecting the liver, radio ablation was done, deciding the depth, how much it should go along the line of transection, thus reducing the surgical time and its corresponding morbidity. They also used tourniquet from below up just above the IVC, just anterior to IVC, and tying the tourniquet so that it prevents the blood crossing from left to the right liver or right to left liver, vice versa. And then they ligated the portal vein also. This again reduced the surgical morbidity and its duration. What is hybrid ALPPS? In hybrid ALPPS, instead of portal vein ligation, we do portal vein embolization and transect the parenchyma. Why it has to be done? See, this is done for colorectal liver metastasis and also for hilar cholangiocarcinomas. In hilar cholangiocarcinomas, this tumor can very well involve the right portal vein, and there is no point in opening the tumor, finding the right portal vein, isolating and ligating it. So in no touch technique principle, instead of opening this area, we can endovascularly do a portal vein embolization, thereby maintaining the principles of oncology and then include the transection portion of ALPPS. These modifications have significantly reduced the morbidity of the ALPPS. But still, ALPPS has got morbidity as high as 25 to 50%, and that is why it has not picked up when compared to that of straightforward portal vein embolization and stage hepatitis. Structures compressed in Pringle's maneuver: hepatic artery proper, portal vein, splenorenal ligament, and hepatoduodenal ligament. One can easily get carried over with first two options, but these are the structures compressed, but totally we compress the hepatoduodenal ligament. Remember, in Pringle's maneuver, we don't isolate hepatic artery proper, we don't isolate portal vein, we don't isolate bile duct, and then compress them individually. Rather, we compress them all together with an intact peritoneum or fibrofatty structures around without individually dissecting bile duct, portal vein, and the hepatic artery proper. So hepatoduodenal ligament is the fold of the lesser omentum on itself on the free end just above the foramen of Winslow. So this can be easily achieved, and this can be used for control of any bleeding from the liver due to trauma or during a transection phase of hepatectomies. So this was just to give you an idea that how easily one can get carried away. Now, what is the action of bilirubin on CVS? This can be rephrased as obstructive jaundice. What is its effect on cardiovascular system? This decreases the ventricular contractility. It increases the afterload. It decreases the peripheral vascular resistance. So the answer is it decreases the peripheral vascular resistance. Now, the chronic biliary injury or the obstructive jaundice has got multivarious hormonal and direct effects on other systems. So what happens particularly, it increases the enhanced nitric oxide synthetase activity. It also increases the neuroendocrine features of biliary epitheliums. So endogenous opioids also produce nitric acid. What happens? There is increased nitric acid and endocannabinoid formation, which also acts similar to that of nitric oxide on the peripheral vasculature. Biliary plasma bile salt levels or the plasma bile salt level increase can cause vagal stimulation. Everything ultimately lead to decreased peripheral vascular resistance or vasodilatation. Now, the disadvantage of this is impaired cardiovascular responsiveness to sympathetic stimulation. So that is the reason why one having obstructive jaundice will ultimately end up having a septic shock. In other words, a patient with obstructive jaundice develops cholangitis and sepsis. The level of peripheral vasoplegia will be much higher in comparison to that of other sepsis. The reason is neuroendocrine features of biliary epithelium secreting endogenous opioids, which include nitric oxide. Per se, it increases enhanced nitric oxide synthase activities on the endothelium. Endocannabinoid formation secretes substances which have effects similar to that of nitric oxide, and plasma levels of bile salts cause vagal stimulation, all culminating in causing decreased peripheral vascular resistance, otherwise called as vasoplegia. Now, colorectal liver metastasis, which among the following is not a contraindication for metastatectomies? So one should remember Fong et al. Colorectal liver metastasis. So they can be subjected for liver resections because colorectal tumors metastasize mostly first to the liver, and from there only they metastasize to rest of the body. So colorectal liver metastasis is essentially considered as still a tumor confined only to the liver, unless it has been proved that it has spread to other portions of the body also. But if it has few features, then it is a contraindication for metastatectomies. Presence of extrahepatic lesions, more than 3 liver lesions, and unresectable liver metastasis. So out of these three, more than 3 liver lesions, one can easily subject them for metastatectomy. The prerequisite is the future liver remnant should be adequate. If the future liver remnant is adequate, for example, there are 3 liver lesions, all confined to left lateral section, then one can safely do a left lateral sectionectomy because the right liver along with segment 4 is easily enough to maintain homeostasis. Now, if liver lesions are present on left liver, one lesion on left liver, one lesion on segment 6, and one more lesion on segment 7, if they are very small, then it can be safely subjected for metastatectomies. Earlier, it was considered at least 1 centimeter margin should be given. Now, these days, it is considered a negative margin is good enough for colorectal liver metastasis. So the number doesn't matter. The future liver remnant actually matters. If extrahepatic lesions are present, for example, nodes, lung, or any other bone lesions also, it is a contraindication for metastatectomy. Unresectable liver metastasis is a contraindication for metastatectomy in colorectal liver metastasis. So what is Fong et al.? Fong et al. Gave clinical risk score to classify the biology of the colorectal liver metastasis. So what are the points included in that? Node positivity of primary tumor, disease-free interval from primary to the discovery of liver metastasis, whether it's less than or greater than 12 months, number of liver tumors greater than 1 or just 1, preoperative CEA levels is greater than 200 or less than 200, and largest tumor of the liver is greater than 5 centimeter or less than 5 centimeter. So whichever is positive in this received 1 and whichever is negative in this received 0. So out of 5, 0 to 5 score was there. Most of poor biology tumors will have a score of 3 or more. Good biology tumors will have a score of 0, 1, and 2. Now the question is, why this was included? Unresectable liver metastasis. Will anyone do metastatectomy in any tumor having unresectable liver metastasis? The answer is neuroendocrine liver metastasis. So even if the patient has an unresectable neuroendocrine liver metastasis, in other words, R1 resection can be done or debulking can be done, or 90% of the tumors can be removed from the liver with safely preserving the future liver remnant, then metastatectomy in an unresectable liver metastasis from a primary neuroendocrine tumor is not considered as a contraindication. Pseudocyst is most common in. Now, this is a very vague topic. The options given include acute pancreatitis, chronic pancreatitis, and recurrent acute pancreatitis. Very difficult to answer for this, but I would go with acute pancreatitis because the overall incidence of pseudocyst is more with acute pancreatitis. Whereas those who become symptomatic is not as high in acute pancreatitis because most of the acute pancreatitis fluid collections, clear fluid collections in particular, may not turn into symptomatic one and they can resolve over time. Those which requiring interventions are usually chronic pancreatitis. So those pseudocysts which require interventions, 15% result from acute pancreatitis and 30% result from chronic pancreatitis. But per se, pseudocyst following acute pancreatitis is common when compared to that of a patients with a chronic pancreatitis. Symptomatic requiring intervention, chronic pancreatitis, overall acute pancreatitis. So what is FNH? False regarding FNH. Which among the following is false regarding FNH? Is the most common benign tumor of the liver. CT shows central scar, which is hypoenhancing or hypodense. Enhancing is not the particular term to be used in CT scan, and it's a pre-malignant lesion. No doubts, it is not a pre-malignant lesion. The most common pre-malignant lesion of liver is hepatic adenomas. not biliary adenomas, it is hepatic adenoma. Now, is it the most common benign tumor of the liver? See, the most common benign lesion of the liver is the cyst. Most common benign neoplasm of the liver is hemangioma. Most common benign tumor. Tumor is usually considered for a solid thing. It is FNH. Okay. So I will come again. Most common benign lesion is cyst. Most common benign neoplasm is hemangiomas, and most common tumor, benign tumor, is FNH. So FNH classically in CT has an hyper dense arterially enhancing lesion with a central scar which is hypodense. How to differentiate this from fibrolamellar HCC? Now, the fibrolamellar HCC also has arterially enhancing lesion with a central scar. 60% of central scars in fibrolamellar HCC are calcified. The arterial enhancement of fibrolamellar HCC is heterogeneous. Fibrolamellar HCC many a times, more than 25% of the times, has vascular invasion. Fibrolamellar HCC 30 to 35% of the time presents with adjacent lymphadenopathy. So these four things differentiate fibrolamellar HCC from FNH. I repeat, fibrolamellar HCC has a central scar, 2/3 of which will have calcification. The arterial enhancement pattern of fibrolamellar HCC is heterogeneous. Fibrolamellar HCC has a tendency to show vascular invasion. Fibrolamellar HCC has a tendency to have lymphatic spread, showing lymphadenopathies. So FNH central scars do not have calcification. FNH has homogeneous arterial enhancement. FNH do not invade vascular structures and they do not produce lymphadenopathies, which is not a complication of Choledochal cyst. Malignancy to a tune of 3%, stones, pancreatitis, and cholangitis. Again, the options were not very clear, but I typically consider stones, pancreatitis, and cholangitis are very common, and these are the complications of choledochal cyst. Malignancies, it is not 3%. Malignancies range between 10 to 30% in adults. What does it mean? Is it so high? Yes. If choledochal cyst is identified in a person above 10 years of age, about 20 years of age, about 20 years of age, the risk of developing any malignancy related to choledochal cyst, it can be carcinoma gallbladder, it can be intrahepatic cholangiocarcinoma, it can be any cholangiocarcinoma, whether it's distal or hilar cholangiocarcinoma, risk is 10 to 30% higher when compared to that of general population. Whereas if the patient is operated for a choledochal cyst, complete excision of an extrahepatic biliary tree is done in a patient with a choledochal cyst before he or she completes the age of 10 years, the chances of them to develop subsequent malignancy is as low as 0.7%. So that is why choledochal cyst should be excised. Now one can resected. Now one can question, since the risk is already high in adults, then why should one resect cold cyst in adults? The answer is the range of malignancy of cold cyst in adults is 10 to 30%. So 10% is still you do surgery earlier, 30% if you delay the surgery or if you don't do surgery. And it increases at a rate of 0.07 to 0.7% every year following 20 years. The risk of malignancy increases at that range. Which are the parameters suggestive of intrabiliary communication of an hydatid cyst? Or the question can be reframed as, which among the following can suggest a hydatid cyst may have an intrabiliary communication? Increased alanine transaminase, increased alkaline phosphatase, size greater than 5 centimeters, and female gender. Increased alkaline phosphatase. So now, what are the features which can predict a presence of an intrabiliary communication of an hydatid cyst? It is very common in males. Pus, when can one see pus? There could be an occult biliary communication. Per se, the hydatid cyst is non-infected. unless someone has done intervention from outside, unless it has got communication with a biliary tree, the hydatid cyst is usually non-infected. So presence of pus in an unintervened patient, you have to think of intrabiliary communication. Fever, development of fever in patient with hydatid cyst. Centrally placed hydatid cysts are more likely to erode into the biliary system. And those hydatid cysts greater than 10 centimeters. These are the predictive features in whom you should think of a probable biliary communication. The question is, sir, pus, how can one know pus? So when one is doing pair, puncture, aspiration, injection, and reaspiration, first thing we do is aspiration after puncturing, because we have to check whether it is bile or pus. If it is bile, straightforward, you cannot inject. If it is pus also, you have to drain them and you cannot inject a spolicidal agent, because presence of pus again is an indirect indicator of biliary communication. So male, centrally placed, greater than 10 centimeter hydatid cyst, in whom he or she had fever, and while doing pair aspiration of pus, all these are predicting things for intrabiliary communication of an hydatid cyst. Boto is done for it's done for gastric varices. These were other options given. I don't know whether these were the actual options given in the examination. Okay. So it is done for gastric varices. Now, while doing Boto, one has to take care of esophageal varices also. Now, esophageal and gastric varices usually occur together. Esophageal varices can happen individually also without gastric varices. But when gastric varices happen, it's very likely to have an esophageal varices in portal hypertension. Now, these varices are the area of buffer. Portal hypertension gets itself buffered in esophageal and gastric varices. If someone blocks one of this buffer area, for example, gastric varices is blocked with Borto, then the esophageal varices size will increase and there is a tendency of rupture and causing bleeding. Now, the esophageal varices should be tackled with either EVL or other modalities like medical management during the gastric varices being tackled with BRT. In other words, isolated tackling of gastric varices with BRTO increases the risk of bleeding from esophageal varices. So whenever one does BRTO for gastric varices, if esophageal varices is present simultaneously, EVL has to be done. Now, what are uphill varices and downhill varices? Uphill varices traverse from below upwards, which are most common in portal hypertension. The vein flow is from below up of the esophagus. Downhill varices usually come in SVC obstruction. This can happen in thoracic inlet syndrome tumors, where it comes through the submucosal or subserosal veins of esophagus from above downwards and then go into the azygos vein and then enter the IVC, SVC well below. Okay, so these two are not indications for Barto. The most sensitive test for chronic pancreatitis, fecal elastase, secretin MRCP, EUS or ERCP. Obviously, ERCP is not the answer. Fecal elastase predicts chronic pancreatitis only in later stage. Now, the question is between secretin MRCP and EUS. So, the predictive value of EUS is very, very high, but the interpretation depends upon the operator. So, it is operator dependent. Secretin MRCP, on other hand, it is not operator dependent. So, injecting particular dose of secretin while doing an MRCP makes the duct characteristic and caliber very prominent. So, secretin MRCP is considered as a most sensitive test for chronic pancreatitis. Fecal elastase, it is cheap and it doesn't require any invasive modality, whereas others are invasive. Secretin MRCP is invasive one way because you need to inject secretin for the patient. So two more questions were there, which I was not able to identify what the exact question was. Whether it's days related question or it's ALPS mortality related question is not known. So ALPS mortality, I discussed initially the mortality rates were as high as 25 to 50%. Morbidity was as high as 50-70%, but mortality was as high as 25 to 50%. So modifications of ALPS came including uh, tourniquet, uh, radio frequency ablations, partial ALPS, hybrid ALPS, and all those things. ALPS still is not picked up all over the world because of its inherent morbidity and mortality, and very less number of appropriate cases available for ALPS. It is not that lesions requiring ALPS are not there, but the patient is not fit enough to undergo ALPS. And the resultant morbidity and mortality is so high. That is why ALPS is still a debatable option for unresectable liver tumors. Now, TASE related question, I didn't have an idea. And since TASE is a very broad topic, I leave it open. So if anyone exactly knows what was the TASE related question, they can ping into the group. I would be happy to answer in the group along with discussion required. So thank you for patient listening. Do we get any questions in this, or do we get any questions from YouTube if someone is seeing? So that brings us to the end of discussion of INI-SS HPV portion of 2024. Thank you for the patient listening. Thank you.